You're listening to the Assembly on Pulmonary Rehabilitation podcast, brought to you by the American Thoracic Society.
Thank you for joining us. We are here with the American Thoracic Society Pulmonary Rehab Assembly podcast today. I'd like to introduce our guest, Professor Kylie Hill from Curtin University in Australia. Professor Hill is here today to talk to us about interval training in pulmonary rehab. Thank you so much for joining us, Professor Hill.
Thank you. Please call me Kylie, and it's an absolute pleasure to be here.
Thank you, Kylie. So I think I'd like to start with maybe just like a general review. What do we know about interval training for exercise capacity in healthy adults?
Yeah, I think that's a great question. Look, I think interval training's been around for a really long time, even in athletic populations to try and optimise their personal bests and their performances. And more recently, we've seen it maybe over the last 10 to 12 years really been used in otherwise sedentary populations. We've actually even seen it featured on, TV as, this novel training approach that is super efficient because you can push very hard in these intervals and you don't need as huge a dose or as huge a duration of time as you might need with continuous. So it's kind of been spruiked, I think, even in the general population as an excellent and efficient training modality. And we've got tons of data out there in healthy individuals across the age range, really from adolescents to reasonably older adults. I think it's very time efficient. So the idea really is that they do bursts of or sprints of kind of moderate to high. Even some studies do super maximal training for a short period of time. And then there's a period of relative rest, which can be complete rest, but most people will do some kind of active recovery, but at a much lower intensity just to keep things kicking over. And you repeat that cycle basically of these bursts and these relative rest periods for a period of time. The duration's a bit out on what the best one is, but it's very efficient. We see big changes in our exercise capacity, so peak exercise capacity measured in the lab, and it's very good for your cardiovascular system in terms of your metabolic outcomes. So I think that it's kind of really caught on, and you see a lot of it in the community, even around where you live. These gyms popping up with super hit or hit training, like it's all the rage, really.
Yeah, and you hit on this. So you're talking a little bit about the intensity of the intervals. And so, I am probably like most people where I think of high intensity, but are there kind of other formulations or are there other ways that we can use interval training?
Yeah, look, for sure. I think there's a bit of, we tend to try and draw a line between the term interval training and intermittent training. So interval training is usually a little bit more structured, and you are trying to kind of go for at least a work period that would be more than you would be able to sustain in a constant fashion. So normally it would be at least more than moderate. The actual upper limit is unclear about what's required, but most people try and really kind of go hard during those kind of burst periods, if you like. In these periods of relative rest. But I think the other thing that we certainly see over in people with central limitation, or indeed probably any limitation in exercise capacity, particularly lung disease, which is my background, is intermittent training, where we will ask people to do whatever intensity of exercise they're able to do. These people have got pretty limited range in terms of their exercise capacity, so they're kind of on or they're off. It's not really like we've got in a healthy individual lots of grades where you can clearly delineate light, moderate, intensity, super, maximal. Well, these guys have a very narrow range of exercise capacity often. So we'll tend to ask them to exercise at a level that makes them, dyspneic or feeling symptoms. And then when it becomes unbearable, we allow them to rest. And that tends to be more on a case-by-case basis, more than a kind of truly scientific prescription of go hard for this long and then rest up for this long. You see a lot of that in clinical practice, and that's just good management, asking them to push into their symptoms as hard as until it becomes intolerable, and then having a rest up and then continuing on. But that's more intermittent training. I think that's pretty commonplace in most pulmonary rehab programs. They might impose the rest, I guess, because they're sore. I've got a lot of patients at the moment with trochanteric bursitis, these lucky ducks. So not only do they have problems with their lung disease, they've also got really bad hip pain. And that's actually the limiting symptom. We also see people with intermittent claudication. COPD is complex, right? But we also see people who desaturate, and how we actually manage desaturation is controversial. Transient exertional desaturation. So sometimes we might put intermittent training in for those reasons as well, like we're pulling them up for some other reason other than just unpleasant dyspnea or leg fatigue. But I think that's good practice. The critical thing really about intermittent training, if I'm being honest, is I think a lot of people with COPD or unpleasant symptoms will push to a point where it gets unpleasant, or they're fearful it's going to get very unpleasant, stop and think that's it. And the critical thing is to get them up and going again when they have enough respite from that symptom. So it's this kind of pushing into it a little bit more each time, as opposed to walking for 3 minutes and thinking it's game over for the day. So that's that's maybe a different way of applying similar principles, but under a different paradigm. Does that make sense?
Absolutely. And it actually takes me to kind of a side point of so much of what we do is treating kind of the fear of exercise and the fear of becoming symptomatic. And I wonder, how do you counsel patients to kind of see the benefits and work through that?
Now you've touched on my new area. Now you touched on a passion project. Well done, Katie. Look, I think we're understanding more and more about this. I think when we used to think about dyspnea, for want of a better symptom, we used to, in the early days, where we stand on the shoulders of giants, right? People have really explained to us how physiologically these mechanisms exist. So thanks to the work from Dennis O'Donnell, we really understand about dynamic pulmonary hyperventilation. Like he's set the scene for that. And there's been other giants that we've stood on the shoulders of, that have talked about skeletal muscle deconditioning. I could rattle off their names. I'm sure they know who they are, but we stand on the shoulders of giants. And certainly my experience has been throughout the 90s and the 2000s and even 2010. There was a very strong physiological approach to the management of dyspnea. It was all about trying to offload the central limitation with bronchodilators potentially, and then also trying to get enough training load onto the muscles to allow them to adapt to improve their oxidative capacity and push back lactate threshold. And all of that stuff's amazing. Like, it's absolutely amazing. And it set the scene of pulmonary rehab into a kind of a more hard science, if you like. But there's another organ playing a role here, and that would be your brain, right? So I know that sounds a bit trite, and I certainly don't mean to dismiss the amazing work that's been done, but how people process that emotional, process that sensation is a huge component. And people have all sorts of very unhelpful beliefs about chronic dyspnea. I mean, I could dribble on about this for a long time, but they have very unhelpful beliefs. So a lot of the stuff that we've done recently is that patients have very low self-worth. They don't think they're worthy of healthcare because they've smoked their whole life, and so they've brought it on themselves. I mean, imagine carrying that around in your head the whole day. They often think their dyspnea on exertion is dangerous. I often hear this is going to cause my heart to fail, or I'm going to have a heart attack. I'm not going to see my grandchildren. And as a result, it's the natural human response to pull back from a sensation that your brain perceives to be threatening or dangerous. Right? So counselling people around that our brain, our amygdala, our emotional centre of our brain, struggles to pick up the difference between acute dyspnea, which indeed can be terrifying and life-threatening, and you should be terrified of that, versus chronic, manageable, stable dyspnea. Unfortunately, our brain still perceives that, or most people's brains still perceive that as a threat. And so they adapt their lifestyle. And that's just common sense, right? Of course, if you think you're under threat, you're going to change your behaviour. I get it. So it's about getting in their head and understanding that this dyspnea actually, the more you give into it, if you like, or the more you pull back, the more it's got you. Does that make sense? So I think it's about me trying to unpack some of these unhelpful beliefs for these patients and explaining to them what we want. It's beautiful. You've got control of your dyspnea, not that your dyspnea has got control of you. So I think slowly we're evolving into psychologists, heaven forbid. But I spend a lot of time now in this space doing kind of cognitive restructuring. I mean, a lot of that stuff, if you're interested, you can read a lot of this stuff now over in the biopsychosocial model around back pain. There's just huge correlates between how people perceive back pain and how people perceive their dyspnea. So we can learn a lot from that area. And they're actually the group now that I collaborate quite strongly with, the people that are working in chronic low back pain around this cognitive restructuring and avoidant versus action-oriented coping strategies. Anyway, that's not really around interval training, is it? But you get my point.
No, I think it's fascinating, but I think, there's so much benefit to utilizing this in pulmonary rehab, but also, again, so much to unpack and break down by the time patients make it to us in these programs. And I totally agree with you. Sometimes I wish I had an additional degree just in behavior therapy and kind of lifestyle changes. So, but when you can really explain these benefits, I think it's so helpful to patients to understand why they're doing what they're doing.
Yeah, I mean, not to spruik my own work, but I wrote a paper about this last year. So if you look me up, one of the authors' name's Peter O'Sullivan, who is a king in physio around low back pain. He did the Restore trial. I know that's not particularly relevant to this trial, but to this podcast. But if you look it up, we kind of align some of the beliefs around back pain with beliefs around dyspnea, and how you can gently help people to cognitively restructure and challenge some of these unhelpful assumptions. And I think we do that. I think as physios, we do that. We just haven't had a vernacular around it. I think that's what this kind of ties it into a bow about some of the stuff, these very meaningful conversations that physios have, but we don't really have a language for it. And And so I think as physios, we grossly undersell ourselves. We do a lot of this, right? But we don't necessarily badge it correctly.
Yes, absolutely. Well, I think that transitions a little bit to my next question, which is, you've talked about the history of interval training, and I'm curious about, I think as a pulmonologist, my initial thought is like, this is going to induce bronchospasm. People who are restricted and have rapid shallow breathing would have a really hard time, but it seems like maybe that hasn't really panned out. Can you tell me a little bit about how the physiology applies with lung disease?
I mean, I think that's a really valid concern, because certainly for patients with an asthmatic component, going hard at the beginning is almost the exact opposite of what we recommend. People have got a strong airway responsiveness component. You would definitely encourage progressive warm-up, and there'd be a very different kind of mantra around that. So the patients that have been most experimented, for want of a better term, or participated in trials are really those with COPD. There are some studies now. There's in fact just been a new meta-analysis published by the group in Greece, in Athens. They're really big in this area, and that's really the group that's really set this stuff on fire. They've really helped us to learn in this area. But they've done a meta-analysis that included a couple of other chronic respiratory diseases, a bit of Dyspnea. I think there was some ILD in there. There may be bronchitis, I can't remember, but certainly no asthma, which kind of speaks volumes, I think, to it's often the devil's in the detail, right? So it's almost who they haven't included that you need to think about. Does that make sense?
Yes.
With COPD is pretty the airways are pretty non-responsive. What you do with them, really, right? And that's it. And I also think it's worthwhile considering that the physiology of this, where you might get concerned for airway hyperresponsiveness, would be in people that have got a big, again, range of exercise capacity. So if you've got someone that's otherwise reasonably, not that ventilator limited, if it's got quite brittle asthma, but it's still got a reasonable exercise capacity, you'd be mad to go hard at the beginning. Whereas my patients with COPD probably have a peak exercise capacity of about 4 mets. So you're not going hard. By definition, they can't even really reach what you and I might consider moderate to or high intensity exercise, like 6, 7, 8, 9 mets is just out the realm of what they can even possibly achieve. Like they're too limited. So I think that's that's the reason I think it's generally speaking always had good results. Because we're dealing with a different phenotype. Does that make sense of patient? The physiology behind it is really interesting, isn't it? So I think we know, I'm sure I'm preaching to the choir here, but what we know about certainly people with pulmonary disease, COPD, is that, of course, they've got a primary pulmonary impairment, but they've got pretty catastrophic skeletal muscle changes as well, right? In fact, they're catastrophic. When you look at them, they're really awful. And we know that skeletal muscle deconditioning independently contributes to their perception of dyspnea. They produce lactic acid unusually early. They produce it steeply. It curtails them. They've got no respiratory system to exhale the CO2, right? They're ventilator limited. So the idea behind exercise training, of course, is to try and get the lungs out of the way and get load on the muscle so that we can actually train the muscle and condition it and improve its oxidative capacity. So in order to do that, you've got to try and reduce central limitation, which is not easy. There's lots of things that have been tried in that area. There's some earlier work on neuromuscular electrical stimulation, where you just go straight after the muscles. There's stuff on proportional assist ventilation, where you try and offload the work of breathing and take over some of that. And these are all kind of similar ideas, where you're trying to either reduce central limitation or put more on the muscle. Does that make sense? Whereas the interval training is cool, because you can actually, because the gas exchange kinetics in COPD are quite slow, you can go quite hard and almost the ventilator system hasn't caught up. Does that make sense by the time they're there? And then if you back off, you're in recovery. So they can actually get these very high intensities, even more than what you can get on a CPET, for very short periods of time if you back off quickly. So it's a beautiful option for really getting a lot of load onto the muscle, particularly the quads on a bike, without the ventilator limitation almost catching up the way you would expect it to. Does that make sense?
Yes, for sure.
And we know it changes. So again, the Greek group, who I think his surname's forgive me, Australians are terrible at pronouncing names other than anything in English. We're shocking at it.
No problem.
They've done muscle biopsies to show that it changes. We actually get similar changes. You see your cross-sectional area, capillary, like capillarization of the muscle fibre. So these are really changes. With this kind of novel training load where you haven't got sustained load on the muscle, you're giving them a break, if you like, and allowing the ventilatory system not to kind of quite catch up. Does that make sense?
Yes.
Yeah.
So, and I'm curious so we could start to get these changes pretty rapidly. And so what should we kind of expect? Is it that people can make it through pulmonary rehab faster, or that patients can complete traditional pulmonary rehab and have even better exercise capacity and reduction in symptoms when they're done? What are some expectations?
Yeah, look, it's a really good question. I mean, I don't think that we have in COPD anyway strong evidence that interval training does better than continuous training. And we might have that over in a healthy population, again, because they go much harder during the interval training. So I don't think we have that, but it's a very viable alternative, and it will allow those people to participate and reap benefits if they're horribly dyspneic, if they're really, really limited and you really can't get far with them at all. This is a really viable alternative, and it also demonstrates, we know you're going to get similar results, but perhaps if we go back to the cognitive restructuring thing, this is my personal rant on this, I think they also have a sense of mastery. They can get this done. They can keep up with their peers. I mean, it's in a modified way, albeit, but they're actually able to participate in exercise without these intolerable symptoms. So there is a way around. Does that make sense? So you're actually giving them a sense of mastery and self-efficacy over their disease, which that's not to be meddled with, right? Like that's a critical part of what we do. So I think that there's a way that they can contribute or they can exercise. I think the other thing about interval training is that it's a really easy adjunct. It doesn't require fancy equipment. I mean, it might require a stopwatch or a wall clock. I mean, it requires a bike that allow you to kind of grade quite precisely, potentially. But, you don't need to wheel in a proportional assist ventilation device, and you don't need to wheel in neuromuscular electrical stimulation and some of these other really kind of fancy alternatives that are expensive and not practical, potentially, in everyday clinical practice. So I think it's something that even a physio working in a rural and remote area, if he or she understood the principles of it, could probably implement, right? And actually allow these patients who are otherwise have got symptoms, usually dyspnea, but not always, limiting them to actively engage in exercise. And again, that's about their sense of mastery over their disease. And you're not doing them a disservice. You're not doing them a disservice because data shows equivalence.
Right. And no, I think going back to the point of really trying to make a kind of psychological breakthrough with patients,
Yes.
to your point, this empowerment piece,
Yes.
probably like so much of what patients feel the benefit from participating in pulmonary rehab, like giving them that in another formulation.
Yeah.
It's just so powerful. So
yeah, it is. And I think in the old days when we started off with pulmonary rehab and they were going after the wrong outcomes, they're really going after lung function, which is incredibly difficult to change in COPD, right? It used to be seen with skepticism and kind of almost distraction therapy. We'll send them over there. It was almost palliation, right? It was kind of, we don't know what else to do. And so that data that came out from, Dennis O'Donnell and Richard Casaburi and Maltese, sorry if you're listening because I've just completely stuffed up your name. And a lot of these others have really set it into a hard science. But I think now we're coming back around that it's not just about the physiology, right? It's not just about physiology. And we know that. Right? We know that even patients that can't manage high intensity, whatever high intensity is in COPD, still see clinical benefits. And that's about master control, or that's about how they're perceiving their disease, right?
Absolutely. Yeah. So you mentioned this a little bit, and I'm wondering if you can give a little bit more detail of it's been shown to be as beneficial as, traditional continuous exercise. Yeah. So tell me a little bit about that.
So there's been a lot of meta-analyses. So I'm sure your listeners know what a meta-analysis is, but for you that don't, it would be a review of the literature, which is an awful lot of work. Don't let anyone tell you it's not. Where you do a review of the literature, you analyse, you pull out all the CTs usually, and you crunch them down. Crunch is a scientific term, of course, in a meta-analysis where you get an overall summary effect statistics. So it's almost like psychologically, if you think, merging them into one mega trial, right? That's kind of what you're doing to one mega trial. And so these are quite useful for individual trials that are perhaps what we call underpowered, where you won't necessarily see a benefit because they didn't recruit or there was too much variability, or didn't recruit enough, or there wasn't enough variability. There's too much variability, So meta-analyses are very useful to overcome the issue of underpowered trials. And there's been lots, to be honest now, meta-analyses. I was involved in one during my postdoc, so that was a while ago now, but there's been plenty more. And they almost all consistently demonstrate equivalence. So the difference between interval and continuous is either not clear, so it lies over the line of no effect, which means that we can't be sure there is a difference. And if there is a difference, it's very, very small and unlikely to be noticeable by the patient. So it's not clearly obvious that it's going to be different as an advantage. And that's a good thing, right? That's a good thing. It gives us two options with a patient. It's not as though there's one that we have to go with because there's stronger evidence. So it really allows you to become very patient-centered in your prescription and choose what's best for them, as opposed to being really strongly guided by the fact that there's strong evidence for one type over another. The thing that's lacking, I think, if I was to go there about interval training, is that a lot of it's done on the background of these fantastic lab-based studies that were done in the 90s, and it's on a bike. They're probably some of the training regimes are pretty tough. Some of the intervals are pretty tough, 30 seconds on, 30 seconds off. And I would just argue that in a big clinical practice where you've got 8 patients going at once, That's a lot of work for a physio to kind of conceptualize 30 seconds on, 30 seconds off for 8 patients up on a bike where there's someone desaturating in the corner and someone with, an intermittent claudication in the back room. And, the logistics of it are quite difficult in clinical practice. But I think the good news about that is that we don't know. There's no strong data to show what the ideal interval is. So in our practice, I go 1 minute on, 1 minute off. Most patients can see it. They can set a timer. Some people go 2 minutes on, 1 minute off. We don't know. We don't know is the answer. But certainly short bursts with periods of recovery is appropriate. Does that make sense? So you kind of tweak it a bit for your patient too, which is nice. The only other thing I would say also is that there hasn't been a lot done on treadmills, and there hasn't been a lot done with ground-based walking. And that tends to be one of the mainstays of what we do. It's the most functional exercise I think we can do for patients. A lot of it's been done on the bike, but to be fair, a lot of pulmonary rehab literature in terms of the hardcore stuff's been done on the bike, which makes sense. You've got complete control of the patient and complete control of the workload. Like, I understand why we do it. It's just that patients don't, cycle around the house, they walk around the house. And so in terms of what you might think to be functional and what won't be what patient-centered outcome, do they really care if they can, cycle at 70% of their maximum for an extra minute? Or if I'm not sure that translates into I can now play with my grandchildren.
For sure. And I mean, you raised an excellent point about this, which is really being able to safely apply it to a program and to clinical practice. And so I'm glad to hear you would run into some of the same barriers that we do in terms of just making sure everybody's on the same page and monitoring, any clinical decline.
Yeah. I mean, logistically, it's difficult if you're going to be really hardcore and constrained about your intervals. And you've got a class and you've got to think about your therapist to patient ratio. And within a class, you always know there are patients that will do well, adherent, can get it. And then there's other clients, as you know well, that struggle, So, and the physio will spend disproportionately amount of time with those ones. So,
for sure.
It's not even playing field. But if you get a great patient who's very compliant, very switched on, it's a great option.
Yeah, that's wonderful. Well, and I like earlier how you highlighted that even, I think about our patients who come in who might be a little less symptomatic, have a little bit more mild disease, and applying this to them in terms of really pushing their fitness level. But you raised such a good point that actually, maybe even the opposite, maybe the patient who's like really debilitated, right? Yeah. So, and getting a lot of bang for your buck.
Yeah. And I think also overcoming the fear, that's a really big thing. So they know that even with interval training, even if the symptoms are horrific or a bit severe, the rest is coming. There's a rest coming. It's not like having to face a 20-minute walk or a 20-minute bike session, where the rest just seems so far away that it's just the whole task is unmanageable. Whereas the rest is coming here. You can count it down with them.
Right. Absolutely. Well, we talked about the benefits in skeletal muscle. Are there other extrapulmonary benefits for interval training?
Good questions, aren't you? I think in COPD, or certainly over in lung disease, I haven't seen any convincing data about cardiometabolic outcomes. Certainly in otherwise the general population, for sure, it does great things for your cardiometabolic outcomes. So there's some data that will improve, lipid profile, insulin resistance profiles. Even I've seen one that's looked at, left ventricular ejection fraction, like really crazy stuff. I think over in COPD, again, I think there's an opportunity for that. But actually changing cardiovascular health with exercise training is a bit of a tricky thing, because if you think about the physiology behind how exercise training improves, or exercise at all improves, or cardiovascular health, probably the most accepted mechanism is through endothelial function. So shear force flying through the blood vessels. And therefore, you have your endothelium releases nitric oxide to cause vasodilation, and nitric oxide also inhibits plaque production and a lot of other cardiovascular benefits. But that's you need to be exercising with a certain intensity to get that release of nitric oxide. And I'm not sure that in COPD a lot of them can get there, right? So it's difficult to show cardiovascular change in these patients. I'm not saying it's impossible, but the studies that I've read in the past that have gone after arterial stiffness or endothelial function or flow-mediated dilatation or markers of these kind of endothelial functions haven't really fully convinced me we're there. Now, look, that doesn't mean that it's not useful. I think, but I do think we need to be a bit cautious to say there's a strong cardiovascular benefit for these guys doing interval training. I think there are benefits, but I haven't seen strong data around convincing cardiometabolic or endothelial function data in COPD. I've certainly seen it in healthies. That doesn't mean it's not useful. It's an area for further research, and I think actually interval training, if any of them can get there, because you actually are going to impose a high mass load they can tolerate potentially for a period of time. So I think that's a really great area for further research to see if we can see cardiovascular or endothelial function changes after a program of really well-constructed interval training.
Well, you bridged quite nicely to my next question, which was going to be, we covered the gaps, but I'm curious, like, what you would like to see in this field of research going forward.
Yeah, I mean, I think there's still so much to do in this area. Pulmonary rehab is such an exciting place to work. Although I think we know that pulmonary rehab, stock standard pulmonary rehab works, there's lots of things that we need to work on. And I think with regards to interval training, I think there's a couple of things. So, we don't know the optimal ratio. We don't know the optimal work to rest period. And look, I don't know that we'll ever get there, to be honest, in COPD. But the stuff that's missing, and this again would be about kind of the shift that pulmonary rehab, I think, has gone through, where it's been very biomedical, very physiologically based. Ask the patients. We only seen one study that's actually said to the patient, what's easiest for you? What's most likely? What are you going to do at home? Do you like this? Do you like that? Actually putting the patient in the centre of this and actually involving the consumers in the decision. I haven't seen any of that. And of course, that would be part of the paradigm shift that pulmonary rehab's gone through. It's still very hardcore physiology data usually. And this idea of putting the patient in the middle of it, I mean, pulmonary rehab's about creating, long-term health benefits or health behaviours. And if the patients need to have a say in that. So I think I've never seen any data that said, what works best for you, what are you most likely to maintain at home. And so although I think we need the optimal interval, I don't know that we're going to get there with physiology. I think we're going to get there through patient choice. And I would actually really like to see that. I think the other thing is that would be more outcomes. I mean, a lot of the outcomes that are looked at in equivalent studies are peak exercise capacity, VO2 peak, or peak work rate on a bike, or, again, lab-based measures. There's less around dyspnea during daily life. So we see things like dyspnea, but it will be with a Borg score measured at the end of a CPAT. Well, again, useful, but patients rarely do CPATs during the daily life. So I'd like to see, CRDQ data or St. George data or fatigue or mastery or some of those other outcomes that perhaps that are meaningful to a patient. Also, things like endurance shuttle walk test. I mean, I'm a big proponent for field-based tests. Walking's their most important activity of daily living. And a lot of these trials focus on lab-based measures, and I understand why, but they're not that patient-centric. Patients, in all the years I've done this with my students, in all the years I've done pulmonary rehab, I've never had a patient say to me, Kylie, the thing that bothers me the most is I just can't cycle to the bathroom. We don't cycle, we walk. They can't walk their grandchildren to school. That's what bothers them. So it'd be useful to know around some of those outcomes that perhaps are very meaningful to patients without dismissing the work that's been done from the physiology perspective, which has really put pulmonary rehab centre stage. And like I said, I'm not in any way trying to dismiss that. I think that's essential. But I think sometimes the patient might be a bit lost in it.
Yeah, that's a really good point, especially when so much of what we do is really trying to implement that lifestyle change. And we know, right, without the right motivation and kind of the right send off, patients don't necessarily always keep up, utilizing exercise as medicine for their disease. So
in some cultures, I think certainly in Europe, for example, maybe cycling's a bit more normal. But in Australia, none of my patients own an exercise bike.
Right.
But they can all walk.
Right. Great points. Well, I want to end our discussion with really utilizing your expertise. And I'm wondering if you can give any suggestions. Maybe there are people listening who haven't really implemented this in their program or are really trying to think about fine-tuning it. And what recommendations would you give to them?
Yeah, a great question. I mean, I think it depends a bit on what equipment you've got available. So interval training, like I said, I think on a bike is pretty straightforward. So the idea, I mean, most people don't have access to a full cardiopulmonary exercise test, certainly in my country, before they come to pulmonary rehab. And I think there are a few centres that do that, but we certainly don't. Canada doesn't too. So I know of some countries that don't just routinely do CPATs, which means it's a bit more art and science about where you're going to start. I think the goal here is to put them up on a bike, choose what ratio you think they're going to be able to manage at home or what work interval they're going to be managed at home. Don't make it too complicated. So, there's some papers, if you get into this, that do all sorts of, sinusoidal fast rhythms. Like, no, we're not doing any of that in clinical practice. That's all amazing, but it's not happening in clinical practice. So, maybe 2 to 1, 1 to 1, there's no evidence. But I think shorter is better. You can probably get more bang for buck on the muscle, right? And we tend to get them to go at the point that at the end of the 1 minute, they want to rest. They're at the point where they're not happy and they want to rest. Does that make sense? So they can push through, but you'd be cheering them on and then give them a break. So a 1 minute break, again, I don't think there's any evidence that you could extend it out. Sorry, I don't think there's any evidence that's a problem to extend it out. So even one and a half. But, in a busy class where there's a lot of requirement maybe for the bike, I would tend to do that for, 5 to 7, maybe up to 10 times for some of the more fit patients if they can manage it. So kind of 1 minute on, 1 minute off, maybe up to 5 to 7 times. Again, it's art and science. It depends a bit. If you're the only patient, and if they're the only patient that you've got one biking for all the time in the world, you could potentially tweak that. But I don't know many programs that run like that. I think scarcity is kind of the model we're running on here. So that's probably where I would start. But I would also make sure, it's fine for them to do it when they come to you, but I'd also try and make sure that they've got a bike at home, or a bike if they're in a residential facility or in a retirement home, that there's somewhere they can get access to a bike and they can start trying it out at home. Because I'm a strong believer that it's all fine and well if they can do it in front of you, but they don't take me home with them. I'm not a feature of their life for the next 10 years. So they need to be able to do it independently and confidently on their own at home. So I think that's the critical thing, is to get them to try it out at home and say what's working, what's not working, and work with them on those. Work with them. The goal is to try and extend. It's the idea is that at the end of it, that they've had enough. Do you get my point? Right? They're not
Yes.
around.
And convincing them.
Enough. Thank you very much, Kylie. Yeah, that's right.
Right. And do it again and again and again.
Yeah. And you really want, ideally, you've done well when with the last minute, they probably can't get through it. Right? Yeah. That's, then you're in a sweet spot. So about, 45 seconds in, they're like, and we're done. That's the sweet spot.
Yeah. So, that's what you're shooting for. Yes, for sure.
Yeah. Just they've had enough.
Kylie, this has been absolutely wonderful. And I really appreciate all of your expertise and the work you've done in this field.
Oh, thank you. Please don't use the word expertise. I just blush when people say that. It's actually been a pleasure. It's been an absolute pleasure working in this area. And I think, you can really change people's lives. You can really change people's lives, right? Like, so there's a strong evidence-based. It's easy to advocate for because there's such a strong evidence-based. And the patients are genuinely appreciative. And you can genuinely see change that's so meaningful to them. It's a privilege to work in this area.
We're lucky to have you in this field. And thank you so much for your time today. And I hope you have a wonderful day.
Thank you.
Thank you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.